So, let me just introduce you to everybody. So everybody, we like to welcome Dr. Camins. He's the Director of Infection Prevention at Mount Sinai, and he's going to be presenting on bone infections today. So thank you, Dr. Camins.
Thank you. I think I didn't change my title. Haha, sorry. I will share that again. Thank you so much for that introduction. I am, it's good. I miss giving lectures to residents. I'm primarily an administrator now, but as you can see here, I actually update a lot of my slides from previous lecture, but I forgot the title page, so I need to update it. But I am a professor of medicine now in the Division of Infectious Diseases, and I actually did some I was on the consult service for 2 days, so I hope I got to talk to a couple of you guys. But I'm hoping with COVID, hopefully that it'll go away soon, that I can do some. I can round as well with the consult team, hopefully mostly at Morningside. So, okay. I actually do not have disclosures to disclose that's relevant. I will talk about pathogenesis of osteomyelitis and septic arthritis today, and we'll talk about, I think I will have some guidelines about what to do for empiric treatment, but I think, as you guys hopefully agree, that for definitive treatment after you've had culture results, I think it's worth calling ID team to come, right? Because a lot of the times this requires IV antibiotics anyway, and so they probably will need follow up with the OPAT clinic. So just to discuss about the background, osteomyelitis, again, is an inflammatory process accompanied by bone destruction caused by an infected organism, right? It is a disease of antiquity. So even among the Greek, they were talking about this, and it's a very difficult to treat infectious disease, one of the most difficult for us, and partly because bone penetration of antibiotics is poor for the most part, or you have to give really high dose. And then probably the only worse potential organ to reach is probably the prostate than the bone. Brain too, but again, the prostate's the worst. There are only very few antibiotics that can really get into the prostate well. In a study that followed, about almost 9,000 diabetics, 5.8% developed an ulcer, and 15% of them actually went ahead to develop osteomyelitis. And this is, a prospective study was done a while back. And really, it does cost that much. And you probably have noticed people with decubitus ulcers or people with diabetic foot ulcers are always coming back, right? And if you just think about one ulcer with osteomyelitis can really cost a lot of money in terms of healthcare costs. They are classified in some ways by how the disease is spread, right? So contiguous spread from the adjacent soft tissue or joint. So meaning if you get osteo from a septic arthritis, then that's contiguous spread. The most common, diabetic foot ulcers are really considered contiguous spread because it's from a soft tissue infection that then become, osteo. And of course, decubitus ulcers are the same way as well. Hematogenous seeding is actually the easiest one to treat, right? Because hopefully the same, you can get antibiotics the same way into that bone because at least the circulation was good, right? The vasculature is pretty good. And then direct inoculation, of course, the most common of these are surgeries, right? When you have prosthetic joint replacement. So the most common still are Staph aureus and coagulase negative staph, if you include prosthetic joints in there, right? And then the rest of these on the list, again, are occasionally encountered only because a lot of the times this is post-surgical, right? So, and then rarely encountered, right? So Mycobacterium tuberculosis, MAC, again, all of these are very rare, but they can be seen as well. So just to show you, this was, I always like this because it illustrated it really well. That's how it starts. So we have a seeding of a sequestrum of bacteria that becomes an abscess. It's either going to go out to the joint, right? So then you would see an arthritis on top of it, or then it will extend to the subperiosteal periosteum, and then you get new bone formation. And eventually, you get a sinus tract, right? So it will leach out, and then that's when you see it out into the skin. So once you have a sinus tract, it's really makes it very difficult because all this tissue now has become fibrotic, and pretty much a lot of the times it may actually involve skin grafting, because again, the tissue gets really fibrotic, and that it's really very tough to approximate them back once you had surgery. In experimental models, osteomyelitis can be created only after an inoculum of large bacteria, so inocula of bacteria. So it actually takes a lot, like you have to have a significant bacteremia, right, to cause osteomyelitis. So at least then, so they are relatively rare events, right? Osteoblasts then can actually digest Staph aureus, and the Staph aureus, again, part of the virulence, can actually survive and remain dormant for a while. It then, renders the Staph aureus more resistant to the action of antimicrobials. So that's why we could see, that's why it's very hard to treat. And then you also see a lot of relapses. Okay. So we have a case study. A 34-year-old male presents to the ER or ED complaining of low back pain that started about a week ago. It has slowly increased in intensity. He denies having any fevers or chills. He works as a landscaper, and mind you, this is actually a real case from a few years back. This is his MRI. Okay, so what do you guys think, right? So there are two locations here, actually involves, and if you look at two vertebral bodies are involved here as well, right? So potentially this is probably from seeding from a bacteremia, right? So was the MRI the best imaging modality for diagnosis? Anyone? Oh, let me see if maybe someone's chatting. Oh, perfect. Yep, Juan says yes, that actually, or should he be started on IV antibiotics right away? If so, which ones? That's more of a trick question, right? Because it depends on the situation. So when I saw this gentleman, he actually had trauma. He fell, he slipped on the pavement and hit his right buttock. And so he had a bruise there. And it's really, actually, it's typical of Staph aureus infections where you can have a history of trauma that could be remote from the site of where the osteo is, but you can have a transient bacteremia that then seeds the bone, okay? And in this situation, I really hope that we could hold off antibiotics until you get a biopsy, or you at least do blood cultures, but really you should work on getting a biopsy because it's easier to treat if you know the pathogen, right? If it's MSSA or MRSA. So as far as diagnostic modality, MRI is now considered the standard of care. Hopefully, for wherever we're going to practice, wherever you will practice in the future, that you can get an MRI. A CT scan with contrast is a good alternative, but again, it depends on how long the infection is there. Nuclear scans are good as well, but I'll just share you the next slide, which actually shows you why the MRI is the best, right? So as far as you go along, sensitivity, specificity, positive predictive value, negative predictive value, the MRI, it actually is superior compared to all these other tests. And again, when I started as an attending, that was years back, and I don't think things have changed. This is a good at least guide, right, or a grid to look at, that if it's an acute osteomyelitis, really the bone marrow, the MRI is probably the best, because of course X-ray, even plain X-ray, will not really be helpful, and CT, while nuclear medicine scans will show the increased uptake, but you could also see that with inflammation, right? So, and again, in terms of subacute, then CT scans are better at it than nuclear scans are good only if you're looking for multiple areas of enhancement, right? So if you actually have bacteremia, then a white blood cell scan would be better. Again, for the most part, even chronic with pelvic osteomyelitis, really an MRI is really the gold standard now in evaluating these infections. Okay, how about diagnosing people, right? And when I say that, it's an MRI can just tell you, well, there's osteomyelitis, but how do you really know? How do you find out what the offending agent is, right? So culturing through surgical sampling or by needle aspiration under radiologic guidance are really very helpful. And so as much as you can, befriend an IR attending or, ortho or neurosurgery to see if they can actually help you in these situations. And, when I was doing a lot more consulting, I would actually then approach, hope and cross my fingers that whoever is on call would be someone who's always much more amenable to getting biopsies, because it really helps, okay? And for the most part, unless the patient has signs of sepsis, meaning they're really febrile with hypotension or tachycardia, we really would like to hold off antimicrobials until you get a good culture, like a deep tissue culture through surgery or again, a needle aspiration. The only exception is that if you actually have a draining wound or sinus tract, and mind you, soft tissue infections with abscess, right? I think I was talking to one of the residents, I think it was an ortho or vascular, where they said, well, my senior resident debrided an abscess. And I said, did you at least send a swab? When you see pus, sending a swab of that pus is really helpful, right? Even no matter where it is, you just send a swab. That really is helpful, because once you have pus, it really will help you in terms of identification of the offending agent. But in a draining wound or sinus tract, really, if you swab it and grow Staph aureus, there's your culprit, right? Because it is one of the most common causes of osteomyelitis. Okay, so for the most part, for vertebral osteomyelitis, spondylodiscitis, or epidural abscesses, the hematogenous route is the most common case, right? And again, it could be coming from skin and soft tissue infection somewhere, that in the case of Staph aureus, the GI tract, when you get E. coli, right? When you have infective endocarditis, especially in someone who's an intravenous drug user, then you will get hematogenous spread of Pseudomonas, or potentially even definitely Staph is always there. And then infected intravenous sites or catheter. There was a patient at Morningside recently that some of you guys may have taken care of in the CCU, who had actually Candida parapsilosis, probably vertebral osteomyelitis discitis, because this patient kept on having candidemia and wouldn't clear, and there was some localized finding or pain, and it looked like it seeded the back, but that's really rare for Candida to do that, but it is very much possible when you have continued bacteremia or candidemia. So again, signs and symptoms, of course, 90% of people will complain of pain and tenderness at the site, right? But only 50% will really have fevers, and only 15% will have some type of neurological deficit, such as weakness or loss of sensation. You know, cauda equina syndrome is really, really rare, and usually those are really severe. So as far as what do you do, right? So at least you can do an ESR. It is elevated, but mind you, again, it could be there could be other things that would cause that. But again, in a healthy patient without any other problems, you know, seeing an elevated ESR would help, because it's actually elevated 90% of patients. Again, a high white count is not always observed. As I already alluded to, X-rays are not very helpful, so you really need an MRI, right? And again, this is based on previous data, is that at least a CT-guided biopsy of vertebral osteo is 50% sensitive. So at least so it's worth trying to get it, because at least you can get it 50% of the time. An open biopsy really is rarely done, but it is justified in someone who may have a percutaneous biopsy, but really has an abscess that you think can be actually be drained. Patients not responding to empiric antimicrobial therapy, and people with large epidural abscesses, again, in those situations, they really need to go in anyway for the patient's sake, because once you have a really large abscess, there's only so much antibiotics can do. And most of the time, I've never had issues with neurosurgeons taking the patient to the OR to get abscess drained, because they do know that that's really the only way you can potentially cure the patient and avoid permanent paralysis. So other hematogenous osteomyelitis that spread hematogeneously are, of course, in prepubertal children, older patients, in injection drug users, and also patients with catheters, right? Again, I already spoke to that. Staph aureus is really the most common, but you can actually see Streptococcus pneumoniae and Haemophilus, especially in kids, right? Who get hematogenous osteomyelitis from either from an invasive infection. Candida is common, especially in people who use heroin. And actually, this is funny. I learned this from a fellow who really looked deeply into it, and that in some cases, when you use lemon juice to dissolve the heroin, you're more likely to see Candida, because Candida species is actually on lemons, right? Can be found in lemons. So just in case, you can interview when you're interviewing the patient. So and then it's worth mentioning, although this is again more common in kids, Brody's abscess. It's just a complication of acute osteomyelitis, sorry for the misspelled word. And it's usually caused by Staph aureus. And really, it really needs one of those situations where you actually need to go in and debride a patient, because there's a pus, within the cavity. And in this situation, there's really no way, no matter how long we treat them with antibiotics, you really would need to to debride it and then give them antibiotics. Okay, case 2. I'm trying to make these like board questions, right? It's not a straightforward answer. So an 18-year-old male with sickle cell disease presents with low back pain that is not typical of his pain crisis. His febrile at to 38.5 degrees centigrade or Celsius. He's tachycardic, but BP is stable. He has point tenderness in the lumbar region of the spine. So, which gram-negative bacillus is most likely to be the infecting pathogen in this case? That's good. Yep. So that's easy enough, but it's probably a board question, right? So it's Salmonella species. Think of sickle cell. I guess Salmonella is very common. They also can get strep pneumo, but I think the likelihood of osteo in these cases are low. Another group that are prone to getting salmonellosis are HIV patients, especially the ones who are not do not have controlled. If they, if their viremia is uncontrolled and they continue to be immunosuppressed, and a lot of the times that's usually from the GI tract. Right, so they have salmonella from a food as a foodborne illness, and then they get bacteremic and get an osteomyelitis. No talk on vertebral osteomyelitis is not complete without talking about Pott's disease, right, which is caused by, of course, MTB. In 50% of patients, if you actually do an MRI, you'll see paravertebral soft tissue abscesses as well. And 50% of patients will have, only 50% of patients will have a positive chest X-ray, because at this point, usually this means that it's a secondary hematologous spread of TB, right? And that at this point, a lot of people may already have, the lung is not the problem anymore. So, okay. I think I already talked about this. Another Staph aureus. Oh, in that situation, actually, that was a real patient too. They did do a CT guided biopsy, and we did get salmonella. So, okay, this is a more complicated situation. 52-year-old female with diabetes for 10 years. She presents with a deep ulcer in the left foot, and that was positive for bone involved using the metal probe test. So, series of questions, and does she need a bone biopsy first? Number one. And the second question is, how about if we swab the wound for microbiological cultures? And then number three, she insists that she does not want any IV therapy. Is this really possible? Okay, what do you guys think about one? If you should always get a biopsy if you can, right? Hopefully you have good vascular surgery colleagues who would do that for us, or ortho. And then how about swabbing the wound? Okay, I'm seeing so I think it depends, right? Swabbing the wound, especially if you have pus, is okay, as long as you know what should be, what you should treat first. So I had Dr. Lipsky, who I will cite in a lot of these talk. I happened to stand by him during one of the ID week presentations. So we both presented a poster. And over this 2-hour period, I learned so much from him about diabetic foot ulcer than I would have my entire life. So, so it depends, right? If you swab it, I'm okay with it, especially if you're having a hard time getting a bone biopsy. But the caveat is that you should ignore the gram negatives. But if you grew a gram positive from that swab, then you should definitely target, while you may still target, treat them with broad spectrum antibiotics, you should definitely target the gram positives in that culture first, and definitely, and then that would really help. Okay, and then the number three, of course, right? We have good antibiotics that actually have really great oral bioavailability, right? So I think number two, and that's how I answered. Number two is depends, right? And then for number three, again, that's why it's always good to get an ID consultant involved, and especially in this situation, unless they're really hard stick. We always try to avoid putting in the PICC line, but I guess things have changed now. ID or somebody has to approve the PICC line anyway, so because of CLABSI. So okay, so again, so this is of course a diabetic foot ulcer with osteomyelitis. It's the most common cause of contiguous osteomyelitis. Diagnosis done by different modalities, right? But again, a probe to bone test is actually pretty good. It has an 89% positive predictive value. It's because bone, right, was never meant to be exposed to the environment, right? So when you have exposed bone, even without destruction, it is osteomyelitis, right? Because we were meant to have muscle and skin over our bone. So when you have exposed bone, forget it, it's osteo, right? So and I think especially in this situation, if there is no signs of sepsis or that they're decompensating, we really would like to hold antibiotic therapy until we really, the last moment we could do in order, we want some cultures available, right? So mind you, if there's a lot of, there's hemodynamic instability in the patient's part, then you should give them broad spectrum antibiotics. So this is actually one of the studies that was done where they compared swab cultures and bone biopsy, right? It was done in France, where they actually just did swab cultures versus percutaneous bone biopsy in patients who did not have antibiotic therapy at least 1 month prior to their presentation. The results were only identical in 17.4% of the patients, right? But when Staph aureus was positive, or there was a concordance of at least 42.8%, but definitely lower for gram-negative bacilli, right? And so there was no adverse events, again, related to the bone biopsy, except for one patient. It just, because I think sometimes we get a lot of saying, well, we're going to harm the patient if we do that, or introduce a new infection, right? Because what you're trying to do is go through a different spot. And so they're saying, well, they're going to develop another ulcer because of from the procedure. But again, this really helps us narrow the antibiotics. So, okay. So these are take-home points, right? And again, I always, Dr. Lipsky actually was part of the team or who wrote the guidelines for diabetic foot and osteo guidelines. So do not treat clinically uninfected wounds with antibiotic therapy, meaning if it's just an open wound that doesn't look infected, you really should not start antibiotic therapy because you're just breeding resistance. Antibiotic therapy should always be combined with appropriate wound care, right? Just not enough to just throw antibiotics at them. You probably, a podiatrist probably needs to follow the patient as well so they can file really, skin or calluses, right? Because again, if you have a callus, it's really hard to heal. The wound will not heal if you have a really hard, thick callus on top of the wound. For mild to moderate infections in patients who have not received antibiotic therapy, it suggests that the therapy just target aerobic gram-positive cocci, Staph aureus, group B strep, right? Potentially even Enterococcus. So, amoxicillin clavulanic acid would certainly be still an option, especially in people who've never received previous antibiotic therapy. In more serious infections, though, you definitely need to start with broad spectrum antibiotics until you have culture results, right? So this was something I was taught when I was an intern, which I had to relearn as an attending, that because there was one study that showed, and I guess the study was biased, or at least it didn't shown to be true, to always treat diabetics with Pseudomonas coverage, especially in diabetic foot ulcers. And it turns out that wasn't really true, unless you do have high prevalence, or unless you knew that this patient developed the infection after exposure to water, right? And then there was one study, prospective study, performed in more than 2,000 patients with diabetes in California, where they found that in 76.3% of all patients with diabetic foot bone infections, they actually saw group B strep in that population. So again, mine is just one study, but again, I mean, the take-home message is that you should definitely treat gram positives first before gram negatives in these situations, unless it's really serious and you need to try to then cover as much as you can. The problem is in people with diabetes, right? How do you get the antibiotic to the site, right? If they have poor circulation, if you have vascular insufficiency, how do you get the antibiotics there? It's very hard. So, one of the things I always did was to recommend, if it's an internal medicine patient and the patient has not been seen by vascular surgery, would be to just, get an evaluation of their vasculature, and then also then recommend them for revascularization if they actually meet the criteria for revascularization. Because no matter how much antibiotics I give them by mouth or IV, if they have poor circulation, then you're not going to be able to treat them, right? Or you're not going to get effective antibiotic concentrations to the area. So it's really important that you also work on their vasculature. And again, broad spectrum antibiotics, of course, beta-lactam and beta-lactamase inhibitors are good, plus or minus fluoroquinolone or metronidazole or Clinda. Linezolid is a good oral option, antibiotic option. Actually, there's been some trial. There's at least one small trial that showed it's just as good as IV, especially if you're targeting gram positives. The deal with linezolid is that it has drug interactions, right? And then there is some risk, again, for myelosuppression if you're going to use it more than 4 weeks. So, but I've actually had some success with patients who don't have serious infection, and I give them levofloxacin and Clinda, or levofloxacin and Flagyl, or even levofloxacin and doxycycline, right? So, and they can, Cipro as well could be a good, and I've done that successfully for 6 weeks, and even sometimes prolong it a little bit until they heal. But for the most part, it is a multidisciplinary approach when you're treating diabetic foot osteomyelitis. Okay. Let's see. Okay. I'm gonna not talk about osteomyelitis associated with prosthetic devices, because I think that probably is worth a lecture on its own. But just to show you that they are increasing in numbers, only because we are replacing hips and knees in a lot of patients nowadays with an aging population, and also, unfortunately, just because we have more overweight, people in the country, or even the world, right? Because of the nature of prosthetic devices, we actually see a lot of coagulase negative staph, or Propionibacterium acnes is causing infections in these cases. Of course, Staph aureus is always feared in these situations because it pretty much increases your risk for reinfection at up to 25%. after one infection. So unfortunately, once your prosthetic, after your knee or hip replacement, if you had developed an infection, it really doesn't bode well for future replacements, because it just puts you at an increased risk anyway. So of course, biofilm can form, right? So you have poor penetration of antibiotics into the biofilm, and pretty much when you get an infection, it really involves removal of the prosthesis. It's very hard to keep them. Okay, but in the big scheme of things, a coagulase negative staph prosthetic joint infection is certainly much easier to deal with than a Staph aureus infection. Okay, just a couple of slides on chronic osteomyelitis, which really, this, as you can see here, this is destruction of the femoral head, acetabulum fusion of hip joint, and this is really from a decubitus ulcer, right? So it's contiguous form of osteomyelitis, and I know that it is. We see a lot of this in medicine, and I see a lot of it in ID. And one of the things I always try to do is to convince a patient that if the decubitus ulcer, whatever the cause was, if the cause of the decubitus ulcer is that the patient is bedridden and cannot walk again, and there's really no, as far as we can tell, the likelihood of them being able to walk again is practically zero. There is no way you can cure them, right? And antibiotics alone, once you have a decubitus ulcer with osteomyelitis, is never curative. So we always want to prevent decubitus ulcer on the other side as well, to really get a definitive cure. And I've had very few of these. A lot of the times I've had success with young patients who may have gotten an accident and they're paraplegic and they just were careless, but otherwise they can actually move around. They're still very mobile in terms of transferring back and forth from their wheelchair. In those cases, a patient who's very dedicated could cure them, right? But it includes nutritional optimization, wound debridement, and care. By that, I mean you have to either have plastic surgery involved and ortho if bone is really, if there's really a lot of bone involvement, because you really have to debride the bone really well to healthy tissue, healthy bone, and then plastic surgery would then come and do a muscle flap. And invariably, it always also includes colorectal surgeons, because we, at least in the success that I've had, especially buttock, decubitus ulcers in people who are in wheelchair, we have to do a diverting colostomy to prevent future contamination of the wound, right? And then followed by systemic antibiotics. I can count on one hand the success I've had in this, but once it works, it really works. But for the most part, the conversation I always had when I have a consultant for decubitus ulcer is I talk to the patient and say that as long as the wound is kept clean and you make sure you take pressure off it, you can reduce the size. And really, unless there's a plan to do the debridement and skin grafting and approximation of the wound, really the only time you need antibiotics is for two reasons. One is there's abscess that needs to be drained, needs to be debrided, and so you give them antibiotics for not 6 weeks, maybe for just a few weeks, 3 weeks at the most, to make sure you treat the abscess. And then if they have a skin infection, if there's cellulitis around the ulcer, then potentially you would just give them 2 weeks of antibiotics to treat that, right? But otherwise, long-term antibiotics, 6 to 8 weeks, will not make a difference in the cure. And this is to illustrate that point, right? There aren't that many studies on prognosis when it comes to pressure-related osteomyelitis, but this was a chart review done of 220 patients, actually by one of my former colleagues. This was at Washington University, where they looked at 220 patients who were admitted to Barnes-Jewish Hospital from 2006 to 2011. And the vast majority were actually either paraplegic or quadriplegic. They had wound cultures available in 51% of the patients, right? And majority of them, and mind you, this is before we knew how to, this is actually what formed my opinion and how, what we found is that 70% of these patients received more than 6 weeks of antibiotic therapy, IV antibiotic therapy, right? And while a quarter of them actually underwent surgery during the index admission, which means to just debride, the wound. And as you can see here, the outcomes, they actually didn't really look at cure because no one really was cured, right? But they showed that if you debride the wound, you are less likely to be readmitted within a year. That's that's really what the outcome of this, right? Because again, it's very hard to cure. It's a very tough thing to see, but really wound care is probably more important, what the wound care nurses do, and prevention of preventing it from getting worse is really the right answer. Okay, next couple of slides, I just want to talk about septic arthritis. Again, I'm talking about non-gonococcal septic arthritis that's not involve prosthetic joints, right? So in just septic arthritis, Staph aureus remains the most common cause of septic arthritis. In kids, actually, it's not a very high mortality rate, but in elderly people, if it's not associated with surgery, it actually has a high mortality rate, can even approach 11%, because for elderly people to get this, they actually have a lot of comorbidities anyway, right? Risk factors actually include joint pathology. So someone with rheumatoid arthritis, osteoarthritis, or crystal arthropathies can get them. And of course, diabetics. And this is, again, post-arthroscopic septic arthritis are very rare, thankfully, right? But they can happen. So it happens about 14 cases per 10,000 procedures. So it's a very low rate, but it is a serious infection. Joint destruction is really important. And I think our orthopedic colleagues know this. And so they're so quick about bringing the patients to the OR for I&D and debridement, because joint destruction can really occur within a few days, right? So it's important then to do this. And so if you see this, especially in patients with underlying arthritis and they have acute pain of just a single joint, then they should really undergo aspiration immediately so you can diagnose them, right? Multiple joints is a little different. Mind you, they could have hematogenous spread in multiple joints, but a single joint should clue you in that it needs to be analyzed. Again, there are several ways, very similar to osteo, right? How do you get the joint seated? Number one, hematogenous route. Dissemination from osteo. So if you have osteo of the bone, it gets into the, but really in that situation where you have that, actually the septic arthritis is secondary. You really need to treat the osteo. And once you treat the osteo, the joint will be fine, although there's going to be some long-term sequela of joint destruction, or at least that, they're more likely to get pain from just the inflammation. You can introduce it when you're doing aspiration potentially, but those hopefully are very rare. And then damage from trauma. Again, in these situations, Staphylococcus, right? Staph aureus really is still the most common, followed by strep, and then of course the other bacteria. Okay. Regarding synovial joint aspiration fluid, so how, what should you suspect? So in someone who has a septic arthritis, you should usually see more than 50,000 white cells, with more than 80% of them PMNs, right? Again, that it's hard. You really need to make sure that you rule out gout or pseudo gout or rheumatoid arthritis as well. Lower white blood counts can occur in joint replacement. So if you have a prosthetic joint infection, that arthritis, you may actually see a low white count as well, because a lot of the times it's either coag-negative staph, which causes very less inflammation than Staph aureus, or even Propionibacterium acnes, right, where there's really hardly any white cells, but they are infected. Synovial fluid glucose or protein is not very helpful. There have been some studies to show that if you actually take the fluid and put it in a blood culture bottle, it actually helps. So, but the more fluid you have, the better it is. PCR testing really has come into play in probably the last 5 years in terms of diagnosis, and it does help, right? So again, I think they're much more accessible now, PCR testing, and so we should do that, especially in situations where an uncommon organism is involved. Other things, I think you should do blood cultures in these patients, right? Compared to cellulitis, blood cultures are positive up to 50% of the time. When cellulitis, you could probably see 4% that are positive for blood cultures in people with cellulitis. You would see, of course, elevated blood count, and we sometimes use the ESR and CRP to monitor their response to therapy. This, I think you guys can look it up, but I wanted to just show you this and highlight it to so this could be board review questions, right? So rat bite fever, you can get, although that might be more ID boards than internal medicine boards, but it is possible that you can get it and get this as a question, is caused by Streptobacillus moniliformis, and a lot of times these are pet shop workers or zookeepers, right, that they would get rat bite fever, and it's more a lot of times it's on the knee. Of course, cat and dog bite, right? Passerella multocida is from cat bites, and then of course and dogs as well, but more cats. But Coptocytophagia is more likely from dogs. And that was the end of but I wanted to share something hot off the press. This was just published January 7, 2022 from MMWR, and I'm switching to COVID a little bit. I just wanted to show this. This is actually CDC data on more than 1.2 million people who were vaccinated between December 2020 to October 2021. And this is data from 465 healthcare facilities, right? And so this is the justification for why we are vaccinating people. And hopefully, if you still have friends and relatives who are not vaccinated, if you are fully vaccinated, and this included Johnson & Johnson, just 1 dose, severe COVID associated outcome was only 0.015%. 1.5 out of 10,000 people had severe COVID, meaning they either had to be intubated, they had to have high flow nasal cannula, and then death occurred at 0.3 per 10,000, right? Although it's not apples to oranges, it's not apples to apples, I did try to look up, 2017 to 2018 was a really bad flu year for us, right? And then when I looked at the 30 to 50 age range, their death from flu was 0.3 to 0.13 per 10,000. Unfortunately, they don't have the overall mortality from seasonal flu. I mean, it really is then with vaccination. Mind you, this is Delta, and we're actually seeing, if you're fully vaccinated, is that we're seeing even less severe cases in Omicron, right? But if you're unvaccinated, we're still seeing, as you guys probably can attest to, that people are still getting very sick from Omicron if you're unvaccinated. All persons with severe outcomes had at least one risk factor, and these are all the risk factors that they said. And majority, the vast majority is 78% of people who died fully vaccinated had at least 4 of these risk factors. So again, while not minimizing, people unfortunately are still going to die, but from COVID, it does, I could say, approach, seasonal flu, right? So, you guys can look this up. It's the MMWR for January 17th. I thought it was an interesting paper, and the fact that it really included, 1.2 million people, which is a huge number, and so we can really make some inferences in this study. So, that is all I have.